It's been ages since we've hosted a Would You Rather episode. And right now, there's nothing we'd rather do than dive into Would You Rather, the antibiotics version. We're thoroughly looking forward to this episode. And if this is your first time listening, Would You Rather is a game-based episode where our guest participant is asked to choose between two options in a question. This is then followed by unpacking of the question and the options by an expert guest. Sometimes there's a correct answer and sometimes not. We're also excited about this episode because you'll be hearing from two of Microbe Mail's team members making their debuts on the show for the very first time. So to start, I'm very pleased to give a warm welcome to Nonkululeko Mkla. She's our Instagram social media manager and now also co-host of Microbe Mail. Hi, Nonks.
I just want to say welcome to our two guests. So my name is Dr. Nonkululeko Mkla. Everyone calls me Nonks. It's easier to say. Newly qualified clinical microbiologist based here in Johannesburg, the root of all the information. I really have enjoyed my stint in Microbe Mail. Usually I'm behind the screen or behind the cell phone screen, so this is very new for me. But I think this is going to be a lot of fun. We've got a lot of good questions today.
Awesome. It's great to have you on board, Nonks. And our expert guest on this episode is Professor Andrew Whitelaw. Hi, Andrew. It's great to have you on.
Thanks very much, Vin, and thanks, Nonks. This is as Vin said, my debut on Microbe Mail, so I'm quite excited to be part of this. I'm a clinical microbiologist and head of the department at Stellenbosch University and Tygerberg Hospital. I won't say how long I've been qualified for. It's too long. I'll leave it there and we'll see. Hopefully get more feedback and discussion going as we go forward. Thanks very much.
It's great to have you, Andrew. And then finally, our guest participant and also Microbe Mail team member is Fatima Suleiman. Fatima, hi, and welcome to our show.
I am excited to be it's a big change from being behind the TikTok and social media scene to now being at the mic. So I am a junior doctor at NHLS in microbiology. I am the social media manager for Microbe Mail's TikTok account. So I'm excited to be here, although I do feel like I'm in an OSCE and I'm nervous, possibly the most junior and less qualified speaker on Microbe Mail yet.
But we're very excited to see what you can share with us today, and we have no doubt you're going to be great. So before we start, we've got a couple of reminders for our audience. Remember to sign up for updates on your podcast player of choice. Also, do give us a five-star rating on your pod player if you haven't done so already. Remember to follow us on social media. We're on LinkedIn, X, Instagram, Facebook, and TikTok. And do remember to interact with us on a Spotify Q&A or on social media or even via email. So all of these links will be available in the show notes for you to find. We always love hearing from you. And last, but certainly not least, do remember to share Microbe Mail with your colleagues, students, and friends. Microbe Mail is available anywhere in the world. So everybody, are we ready to play? Would you rather the antibiotics version?
Ready?
Awesome.
Yeah.
Okay, great. Fatima, we're going to head into our very first question. So number one is, would you rather use nitrofurantoin or fosfomycin to treat a community-acquired urinary tract infection?
Okay, so community-acquired UTIs are something that I am quite familiar with, coming from a district hospital last year during internship, something we saw every day. So I know the guidelines did recommend fosfomycin or nitro, and we did preferably use nitro last year. But personally, I know I'm non-compliant. I would not end up taking the whole 5-day course, 6 hourly doses of nitro. So I would go with fosfomycin for myself.
Okay. And if you were treating a patient?
I would go with nitro because I think I might be wrong, but I think it has a greater clinical resolution than fosfomycin.
Okay. Let's see what Andrew has to say. Thanks, Fatima.
Okay, thanks. So one of the cliches that I always try and teach the medical students is that whenever you're faced with a difficult question, the first thought that should come into your mind is, it depends. And I think this applies to many of the questions we're going to tackle today. I think maybe just to be pedantic, the first thing we should just clarify is when we talk about community-acquired UTI in this context, we're talking about sort of uncomplicated lower tract infection if you're looking at a upper tract infection, complicated infection, your choices are very different, and in many of those cases, neither nitro nor fosfomycin would be appropriate. But in the context of an uncomplicated cystitis, yeah, you're basically tossing up a 5-day, sometimes a 7-day course of nitrofurantoin versus a single dose, sort of one and done of fosfomycin. And I think Fatima's kind of highlighted one of the biggest issues here is that, at least in some of the studies, nitrofurantoin did have a better resolution or better clinical outcomes than fosfomycin, but it's a more complex regimen to take. And people taking four tablets for 5 days, your adherence is likely to be far less than a single dose of fosfomycin, which you can, even observe in a clinic and get it taken there. So from that perspective, fosfomycin is probably the better option in terms of patient adherence. The efficacy, there was a randomized trial published a couple of years ago where there was certainly a significant difference with nitrofurantoin had better outcomes. That also depends on what definition you're using to define clinical outcome, and different studies have looked at different kind of definitions of outcome, and in a number of studies the clinical efficacy of nitro and fosfomycin have been fairly similar. So it's actually quite hard to unpack whether one is better than another in terms of clinical outcomes. It does depend on what you're defining. So there's a kind of a gray area. I think the other concern with using fosfomycin is that repeated and sort of fairly frequent use has been shown to start generating resistance to fosfomycin. And that will potentially be a problem with treatment of UTIs, but maybe more importantly, there is talk about potential use of fosfomycin as a reserve agent for some of the multi-resistant gram-negatives, either ESBL producers or CREs. And there's some clinical trials happening and being planned to look at fosfomycin for that indication. And if fosfomycin does become a reserve agent for multi-resistant infections, then you would want to limit its use for common community-acquired infections to slow down the emergence of resistance. So again, that complicates your decision. And then I think the last point, just in terms of monitoring resistance, testing for susceptibility to fosfomycin, the methodology is really only applicable for E. coli and some of the enterococci. So it's difficult to track resistance to in other organisms. On the other hand, for nitrofurantoin, we know that a number of the gram-negatives have intrinsic resistance. So if we really, for UTIs, we're focusing on E. coli anyway, but by and large, so that's probably less of an issue, but it is just a consideration. So the bottom line is I don't think there's a clear winner in this question. I would probably err on the side of nitrofurantoin because of the desire to reserve fosfomycin for potential future use. But I would worry about adherence. So sometimes I flip a coin and almost do what Fatima does, sort of do one thing for myself and another for my patients, depending on what the preference is. And maybe the important lesson is discussion with the patients and having some sort of assessment on what their preferences are and explaining kind of the risks and benefits of both drugs for your patients.
Yeah, thanks, Andrea, and thanks for unpacking it so nicely. So I think what's really great about what you addressed is the IV fosfomycin use. So as much as we're talking here purely about UTIs, we must always remember that many of these agents are used for other treatments as well, or other types of infections, and fosfomycin is certainly one of those that the spotlight is on. And yes, absolutely, having that discussion with patients to find out which of those regimens are they in fact going to have a preference for, and preference particularly related to what their lifestyle might be. If they're not able to wake up in the middle of the night to take a dose of the antibiotics, are you really going to get dosing appropriately? And that's quite important to consider, because again, that would drive resistance if it's not being taken appropriately. So great, that was wonderful. Certainly not something anyone seems to be able to put their head on the block for.
No.
So I think we can move on to question 2 then.
Awesome. So I'm going to ask the second question. So Fatima, would you rather treat an ESBL urinary tract infection, so a urinary tract infection caused by an ESBL producing organism, with amikacin or ertapenem?
So maybe this is a bit of a trick question for me, because in KZN, in most of the hospitals I've worked in, we've never had ertapenem in stock. Our pharmacy usually doesn't have it in stock. So, I would have to go with amikacin. But otherwise, if I was in a resource setting that had stock of ertapenem, I would go with that. I know it's generally well tolerated and has good efficacy for ESBL organisms.
And are there any other factors that you would consider that would determine your choice, given that you had ertapenem available?
I know amikacin does achieve high concentrations in the urinary tract, so that would be a pro for that.
Let's see what Andrew's got to say.
So this is another question where I'm going to start off with it depends. I mean, I think again, Fatima brings up a very important point that we're assuming that we have reasonable access to both of those drugs. And I think we also need to just differentiate whether you're talking about a kind of an uncomplicated lower tract infection or certainly a urinary infection without any systemic signs of sepsis. So you're not concerned about a bacteremic urinary infection. And for a kind of a mild, non-bacteremic, severely ill patient, I would actually be fairly happy with amikacin. As Fatima says, you get very good levels in the urine, and it's an effective drug. And there've been a few studies that have shown that you get good clinical outcomes using amikacin for treating ESBL UTIs. Again, we're assuming that the organism has been shown to be susceptible to amikacin. There are certainly a proportion of ESBL producing gram negatives will be resistant to amikacin as well, and then we wouldn't use it. The other consideration is just looking at underlying renal function. So amikacin is nephrotoxic. If there's underlying renal impairment, we'd avoid using it. In the elderly, we'd also tend to avoid using amikacin. Even if the renal function looks sort of normal, there's less renal reserve and probably a higher likelihood of causing some degree of renal insufficiency using amikacin. The definition of elderly, I think, varies depending on who you are. So when I was younger, 50 was elderly. Now that I'm getting older, elderly moves up. But I think we kind of use 60 as a ballpark figure for elderly, but that's also, I mean, you get young 60-year-olds and you get old 50-year-olds. So I think you need to be a little bit nuanced about that. But certainly somebody the older the patient is, the more concern you would have about using the aminoglycoside. Otherwise, and if amikacin is contraindicated for whatever reason, then ertapenem is also an excellent choice. And so the reasons probably to try and avoid ertapenem, again, we're seeing more and more carbapenem-resistant Enterobacteriales throughout the country and globally. And using amikacin is really, it's a carbapenem-sparing regimen. The less carbapenems we use, hopefully, the slower the emergence of the CREs is going to be. We're not going to stop them, but if we can just try and reduce the selective pressure as much as possible. And that would be my main reason to use amikacin in at least a proportion of patients with ESBL UTIs where it's clinically appropriate and not contraindicated. Thanks.
I think that was very insightful, especially when it comes to AMR. As microbiologists, we're trying our very best from different avenues to try and target this mountain of an issue. And I think trying to use options that are carbapenem sparing is, one of the low-hanging fruits. Yeah, but as you said, it depends. Thanks.
And I think the reason we actually put this question in is because I think, at medical school, because the students are so overloaded with information, sometimes the microbiology has to be taught in a very simplistic manner. And so often I think the students will get, drummed into their minds, if there's an ESBL equals use of carbapenem, and the intricacies of ESBLs in different body sites or different organ systems, and the fact that they could be treated with a non-carbapenem antimicrobial, I think is one of those things that is not clear, or crystal clear certainly, to most clinicians. So we're hoping this was a helpful question if you're a clinician or a student listening. And then question 3, Fatima, are you ready for this one?
Yes.
Would you rather use cefazolin or cloxacillin to treat a methicillin-susceptible Staphylococcus aureus bacteremia? So this is an MSSA bacteremia. Would your preference be cefazolin or cloxacillin?
So I would initially go with cloxacillin, especially because of my reading in the guidelines. I know cloxacillin is recommended for methicillin-susceptible staph. But I'd also want to know about the patient's renal function, their hepatic function, because I would be worried about nephrotoxicity, hepatotoxicity. So again, like Prof says, it depends.
I think we should change the name of this episode to Would You Rather, Does It Depend?
What does it depend on?
What does it depend on? Yeah. Tick all that apply. Okay, great. Andrew, what's your thoughts?
So the bottom line, I don't have a clear preference. My kind of inclination is to use cloxacillin, but I think that's primarily because that's the way I was brought up. So when I trained as a registrar and certainly as a microbiologist, we almost defaulted to cloxacillin, and I don't really know why. I think it was what was available on tender, so you used it. It's quite interesting of looking at some of the data. There's also kind of mixed results if you're looking at some of the head-to-head studies of cefazolin versus clox for MSSA bacteremia. Some studies show cefazolin's better, some show clox is better, some show the difference. There was a meta-analysis published recently which actually came out down in favor of cefazolin. I can't remember what the difference was. I mean, how significant the difference was. But they also make the point that a lot of the studies are of kind of dubious quality, or kind of, there's not a lot of high quality data. So the short answer is I don't think we've got a lot to hang our hat on in terms of choosing one over the other. I think just 2 points. One, the cefazolin dosing regimen is probably slightly easier than the clox dosing regimen. 8 hourly versus 6 hourly. In a hospitalized patient, that shouldn't make a difference, but we know it does. And then, I mean, as Fatima says, certainly the cefazolin seems to be associated with fewer side effects than cloxacillin, and that may be one thing that kind of nudges us towards cefazolin. It also very often comes down to kind of what's available in your setting, and if you've got either one available, they're both very good drugs. Well, kind of the treatment of choice for Staph aureus bacteremia. So I don't feel terribly strongly one way or another. And maybe just the last point, there has been quite a lot of literature around the inoculum effect, and this is a microbiological pedantry probably. People showing that with cefazolin you get an inoculum effect, and if you've got a high inoculum, the MIC jumps up. That doesn't seem to impact the clinical outcomes at all. So it's a laboratory phenomenon, but we don't think it's that clinically relevant. So I think just be careful about using the inoculum effect is not a good reason not to use cefazolin based on the clinical outcomes. Thanks.
Great, thanks. I agree with you. It is quite a tricky one to think about. And really just from a practical perspective, knowing that potentially, in many situations, we know that stock outages are a problem. And if your hospital normally keeps cloxacillin for your MSSAs and you suddenly have a stock outage problem, just really important to know that cefazolin is an equal alternative agent for these infections. So that's just really what I wanted to add there. And it's good thing you brought up the inoculum effect. I think that's really important. Thanks, Andrew.
That's interesting to know. I didn't know that.
Okay, so question 4. Would you rather treat an abscess after surgical drainage with cloxacillin in combination with metronidazole, or would you rather use coamoxiclav augmentin?
Firstly, I wouldn't jump onto antibiotics after surgical drainage unless I'm worried about something in particular, like the patient has extensive cellulitis or multiple abscesses, or patient isn't doing well, has a fever. So that's my first thought process. I'd consider if the patient has comorbidities, immunosuppression. So I wouldn't immediately jump onto antibiotics for every abscess, even after surgical drainage.
So sorry, Fatima. So let's say from the drainage, we cultured an MSSA, methicillin susceptible Staph aureus, and the patient was symptomatic, had a spike in temperature, and you wanted to start an antimicrobial.
I would go for cloxacillin. That's has good cover for MSSA, Staph aureus. I would go with that. I put my money on cloxacillin.
That'd be a good bet. Prof, do you have a differing view or similar view?
I think fairly similar view. So, I mean, I think I was very, very happy to hear Fatima saying that you don't necessarily need to give an antibiotic at all. So I think very often for superficial abscesses, drainage is all you need, and don't start throwing antibiotics around as well. But yeah, if there are reasons to give an antibiotic for an abscess, it depends probably on the site of the abscess. So you guys didn't say whether it's superficial or deep or where it is. So for a superficial skin soft tissue abscess, where staphylococci are most likely, and I wanted to give an antibiotic, probably cloxacillin. I'm not convinced the metronidazole is indicated for the superficial abscesses, to be honest. I think those are most likely to be staphylococcal, and I don't know if the anaerobes are that much of an issue there. And I would say if you have drained it, there's probably even less evidence to start throwing anaerobic cover for superficial abscesses. I think for deeper abscesses, intra-abdominal abscess, then you want the gram-negative cover in particular, and probably anaerobic cover, and that's where comoxiclav would be better, assuming it's properly drained as well. Or even a kind of a superficial-ish abscess that is close to a site where you might get gram-negative. So perineal abscess, then you probably want to add use comoxiclav for the gram-negatives. Sometimes in diabetic feet, we know get all sorts of organisms, and if there's an abscess associated with that, then you may want to use comoxiclav as well. But I think for the most part, superficial abscesses, either nothing or probably cloxacillin. There's interesting, I mean, there are a couple of studies coming out of the US, and I think the US and some meta-analyses that they also, I mean, cotrimoxazole seems to work very well as an agent for treating superficial abscesses that have been drained as well. So we can also think of that as an alternative. Thanks.
Thanks, Prof. That was very enlightening, especially about the use of Cotri. I think Bactrim, cotrimoxazole, has really fallen, especially in the age of HIV, it has fallen within the category of prophylaxis. No one really thinks of it as an agent for treating, commonly encountered organisms. And I think perhaps this question, we could have phrased it better, because I see we haven't been clear about both where the abscess is, but also what has been isolated. So definitely with only an MSSA isolated in a superficial abscess, clox on its own would be appropriate. But whether or not you would need additional anaerobic cover, I think that is what clinicians need to be asking themselves. Thanks.
So before we move on to the next question, Fatima, I am sending you a virtual gold antimicrobial stewardship badge for firstly saying that you would not treat with an antibiotic.
Definitely. But I know patients would ask for antibiotics. It's the impulsive thing to do.
Yeah. So interestingly, just as an aside comment, so we as clinicians, I think people say that quite a lot, the patients are the ones who are insisting on getting their antibiotics. But there are a few studies which have been conducted, particularly in outpatient settings, where patients have been interviewed and asked after their consultation with the clinician, did you ask for an antibiotic? And in fact, the majority of patients are not asking for it. So there is this disconnect between what the clinicians think is going on and what is going on from the patient.
Wow.
Very interesting.
And I think doctors should take the opportunity to educate patients about AMR and antimicrobial stewardship.
Yeah. I'm going to take that as an opportunity to give a plug for one of our older episodes. So we had, I can't remember the episode number right now because we're doing this off the bat. We have an episode entitled Communicating Antimicrobial Therapy. And that was a conversation with ChatGPT, where we spoke a lot about how to appropriately communicate antimicrobial therapy to patients, both from the patient perspective in terms of what to ask of the clinician and some ideas for the clinician of how to communicate better. Okay, so we're going now into question 5, and this is something that I think is treated fairly commonly in the outpatient setting. So Fatima, would you rather treat a mild community-acquired pneumonia with amoxicillin or azithromycin?
So I would go with asking about the patient. I would want to know their CUP 65. I want to know if they have any underlying comorbidities, and emphasis on mild community-acquired pneumonia. So that would be my green flag to go with amoxicillin, because I wouldn't be suspecting anything atypical. I wouldn't want to jump to azithromycin if it's just a mild community-acquired pneumonia.
Great. Thanks. Andrew?
Yeah, I agree 100%. When I read this, I was looking for the trick somewhere. But yeah, if you look at the South African guidelines, I think the EML, they're also talking about ampicillin or amoxicillin for mild pneumonia. And then for the more severe cases, then you may want to consider adding a macrolide to broaden the spectrum for atypicals. Azithromycin on its own for a mild pneumonia, it might work, but I would think it's sort of very much second choice, and possibly in someone who's got a severe beta-lactam allergy, that maybe when you consider an alternative like that. But I think for anyone who comes in with a mild community-acquired pneumonia, amoxicillin should be your first thought.
Yeah. Yeah. So I mean, this question was really targeting the outpatient setting where we know macrolide use is unproportionally high
Yeah,
compared to what the epidemiology is for
absolutely.
community-acquired pathogens for pneumonia. So really, there isn't really a role for empiric use of azithromycin routinely in that sort of setting. But great. I think this one is a straightforward one. We all agree.
Yes. There's very little depends in here.
Yeah. No
Yes.
Perfect. Thank you both.
Okay, question 6. Keeping in the theme of pneumonia, would you rather treat an MRSA pneumonia with linezolid or vancomycin?
I've observed both being used in the wards, either vancomycin for some patients and linezolid for others. So I would go with linezolid because for vancomycin, I'd be worried about the patient's kidney function. And linezolid, I know has good penetration to the lung parenchyma, so I would think that's the better option.
Yeah, that is a fair selection. Prof, do you have anything to add to that?
So when linezolid first came out, and some of the earlier studies of linezolid for MRSA pneumonia did suggest that linezolid was clinically superior to vancomycin. I think there have been a number of subsequent studies, and one of the kind of latest meta-analyses, if you're looking at clinical outcomes for MRSA pneumonia, that there's nothing to choose between the two. They've both got side effect profiles. So vancomycin, there's potential for more nephrotoxicity. For linezolid, you get the hematological side effects. And I think the rate of side effects are fairly similar between the two patient groups as well. So I think for in terms of clinical outcomes, it doesn't seem that there's much to choose between the two. And then your decision making then comes down to which is safer. In someone with underlying renal toxicity, then you may want to go with linezolid, but otherwise probably not much to choose either. And then you're looking at sort of stewardship considerations and possibly other factors. From a stewardship perspective, I kind of want to stick with vancomycin and reserve linezolid for when we do need it. And linezolid is becoming, or can be an important part of an MDR TB regimen. That's something to just keep in the back of your mind if you're treating respiratory infections in general. The big advantage of linezolid is the possibility of using it as an oral agent. So my kind of general approach would be confirmed MRSA pneumonia, probably vancomycin to start with, especially if there's no contraindications. Once the patient's stable and you want to get them off the vancomycin and get them home, then certainly switch to oral linezolid. I mean, I think at times we probably focus too much on the stewardship side and sort of, we don't want to use linezolid, but if it gets the patient out of hospital off the IVs, absolutely. And that would be the biggest drive for me to use oral linezolid in this situation. Thanks.
Thanks. Thank you for the answers. I completely agree with both of you. So definitely an initial vancomycin, intravenous vancomycin for the pneumonia. Where I've worked in some institutions, it's difficult to get access to that linezolid, or clinicians are unsure of how to dose it. They don't know if there's underlying tuberculosis. Sometimes these patients come in very unwell with comorbid immunosuppression from HIV. So I think it's fair actually to start with vancomycin. But on the other side of the coin, there are all these side effects from vanco, and there are a lot of clinicians out here that are very concerned about the renal dysfunction that comes with vancomycin. So I think just from a stewardship point of view, it would be fair to start with vanco and then de-escalate to an oral agent. I think then you just need to determine the duration of the treatment that you're going to keep the patient on, because of those long-term adverse events that have been associated with linezolid. Fortunately, there is an alternative that I have come across to linezolid, but it is exceptionally expensive. So I'm not sure how soon that will hit the public sector.
Nongs, is linezolid available in the private sector in South Africa?
Yes, so it was launched, I think, last month. It's a once daily dosing of 200 milligrams, also oral. Similar spectrum of activity as linezolid. Shorter duration, I think, longer duration, sorry, 6 days, whereas linezolid is being marketed for 5 days, but it is a lot more expensive. I don't want to quote an actual figure, but when we calculated it at the time, it's at least 5 to 10 times more expensive than linezolid.
Wow.
Yeah.
Hopefully, at least the cost will be enough to deter people from using it inappropriately.
Yes. Yeah. Yeah.
Okay, great. So we're trudging along, Fatima, and fortunately, you're over the top of the hill and we're on our way down. We're at question 7 of 10. So you can breathe soon.
Okay. Haven't felt this since final year in med school.
Shame. So question 7 is, if you're suspecting a community-acquired meningitis, would you rather treat empirically with ceftriaxone or ceftriaxone plus vancomycin?
Okay, so I'm going off the assumption that this is an adult patient.
Yes, let's go with that.
So I would firstly think about the standard treatment guidelines, which usually says that bacterial meningitis we would treat with ceftriaxone, but I wouldn't leave it at that. I'd also consider the patient, their age, and am I suspecting a resistant organism? Because the reason you said vancomycin is making me think of resistant strep pneumoniae. But I know in our setting in South Africa, I'm not too sure if it's something that's common, resistant strep pneumoniae. So that's my thought process.
That's a great thought process, and you're actually going exactly down the line we were hoping for. So let's hear Andrew's thoughts on it.
Yeah, no, so exactly correct. I mean, I think your thought flow is exactly what we want to see from everyone who's using antibiotics. So we use ceftriaxone empirically for kind of adult meningitis because it covers the commonest pathogens, pneumococcus, meningo, and Haemophilus. Although Haemophilus generally is very uncommon, and particularly especially in adults. So it's really meningococcus and pneumococcus. And we are seeing some cephalosporin-resistant pneumococci locally, but the rate is still very low. It's a couple of %, and it's certainly not high enough to warrant adding empiric vancomycin to our treatment of community-acquired meningitis, which is a major stewardship sort of decision to make because it's going to result in quite widespread use of vancomycin. And we're not seeing the sort of treatment failures with ceftriaxone, and we're certainly not seeing, as I said, we're seeing a handful of isolates with elevated ceftriaxone MICs, but not enough to warrant changing your empiric therapy yet. So ceftriaxone is absolutely correct.
Well done, Fatima. And yeah, thanks. Another straightforward one, fortunately, at least. Thanks.
Yeah, we seem to be doing very well already on question 8. So now, would you rather treat C. difficile, Clostridium difficile gastroenteritis with metronidazole or vancomycin?
So a lab confirmed C. diff.
Yes, so let's say GDH positive, toxin positive.
So the first card I would play would be flagell. I wouldn't immediately go for the vancomycin. Maybe I'd save the vancomycin for a second-line treatment if flagell failed, unless I'm particularly worried about this patient. If it's a very sick patient, an ICU, immune deficient patient, they have comorbidities, then I would jump to vancomycin as a first line.
I just want to emphasize that it's oral vancomycin that we are referring to in this question, not intravenous. Prof, do you have anything to add?
Yeah, so we should actually be using oral vancomycin as our first line for even sort of mild to moderate C. diff gastroenteritis. It's a more effective agent than metronidazole. And I think the only place for metronidazole is probably in settings where you can't access oral vancomycin or any of the other alternative therapies. So the alternative is fidaxomicin, which I think is limited availability in the state sector anyway. So oral vancomycin first, or oral vancomycin plus fidaxomicin for severe cases, and metronidazole if you can't access either of those two treatment options. We must also remember, I mean, and it's this sort of contradiction, but one of the key parts of C. diff management is also stopping the offending antibiotics. And it always sounds kind of contradictory. We're going to stop antibiotics and we're going to start another antibiotic to treat antibiotic-associated diarrhea. But that's the way it is. Thanks.
That's interesting to know. I always thought metronidazole was the first line.
It used to be up until probably about 5-10 years ago. And I don't think that messaging is actually getting through. And that's one of the challenges, I think, with all sort of guideline updates. It's great to update the guidelines, but if nobody reads or sees or practices them, then they don't really have an impact. So, I mean, hopefully something like this podcast, but, you know, probably as a microbiological or infectious disease grouping, also need to think of better ways of getting some of these messages across and trying to make sure that guideline changes are incorporated into routine clinical practice.
Yeah, absolutely. And so just to add to that, we'll make sure that the South African C. difficile guidelines are added to the show notes for anyone who's interested in looking up that information. Because I think you're right, Fatima and Andrew, the guideline is there, but the message hasn't filtered across to the clinicians on the ground necessarily. Any further comments from you, Nobs?
Yeah, thank you, both Prof and Fatima. Fatima, you're not wrong. There are a lot of clinicians that would have answered exactly as you have.
Absolutely.
Yeah, and what I have experienced is it's more the pediatricians that are more concerned. What can I say? They have a history of using Flagyl for quite a lot of their pathogens in patients that present to them. And what I found is that they are more comfortable in using metronidazole in managing their patients. And so in a child above 2 years in whom they are strongly suspecting that C. diff is actually a pathogen, it's not colonizing, they will actively tell you that, no, I would prefer to use Flagyl. So hopefully this episode will be able to spread the word.
That's interesting, Nobs. Thanks for that. So your penultimate question, Fatima, would you rather treat a mild to moderate watery diarrhea with ceftriaxone or ciprofloxacin? So it's mild to moderate and it's a watery diarrhea.
So a watery diarrhea, I would want to consider if I'm suspecting cholera, if I'm suspecting dysentery. My first instinct would be to treat symptomatically rather than with antimicrobials for a mild to moderate diarrhea. Generally, I would go for the antibiotics if I'm suspecting dysentery or cholera. So my answer is symptomatic management.
You're on a roll today, Fatima. You're getting a second gold antimicrobial stewardship badge.
Really good. Really good.
Thank you.
Yeah, no, I was going to say exactly the same thing. It's another gold star for Fatima. And sorry, Fatima, you sound as though you're kind of being put on the spot here all the time. But I think this is a scenario that's also obviously very common. I mean, diarrhea is unfortunately a common illness in adults and children in South Africa. And diarrhea, most cases are viral, in which case antibiotic is meaningless. And even some of the bacterial causes, so the sort of mild salmonella gastroenteritis, typically resolve spontaneously without antibiotic therapy. And really for mild to moderate diarrhea, mild to moderate watery diarrhea, there's no real place for antibiotics. If someone's got chronic diarrhea, it needs to be investigated. If there's dysentery, sort of blood and or sort of mucus in the stools, then you would be suspecting either Shigella or amoebiasis or something, and then an antimicrobial would be appropriate. And even for cholera, rehydration is the most important part of therapy. And I mean, people do add antimicrobials, which might lessen the sort of duration of diarrhea, but the rehydration, even without antibiotics, has got to be the most important part of managing a case of cholera. So, thanks.
Great. I think that pretty much covers everything related to watery diarrhea. And yeah, fairly straightforward.
I think straightforward, but I think not often done properly.
Yeah, that's true.
Yeah. Okay, final question. A patient is booked in for an elective cesarean section. Would you rather treat her or rather administer 1 dose of Kefzol, or 3 doses of Kefzol as surgical prophylaxis?
From my time in an obs and gynae department, working in theaters where there's 10, 20 Caesars a day, we would just give 1 stat dose of Kefzol. I've only ever seen consideration for an additional dose is if the patient was perhaps obese or if the procedure was unexpectedly long with complications, then I've seen an extra dose added. But my answer is a single dose of Kefzol.
Love that, Fatima. I love how you've incorporated your experience. Let's hear what Prof has to say.
Yeah, again, another gold star. So antibiotic prophylaxis, for the most part, should be a single dose given pre-operatively and is kind of close to induction. So you don't give it 3 hours before the surgery, give it sort of 30 to 60 minutes preoperatively. And in general, for most surgical procedures, a single dose of prophylaxis is all you need. As Fatima said, prolonged surgery, I think after about 4 hours, you may want to give a second dose. Or if there's excess blood loss, where unfortunately your kefazolin is now pooling on the floor of the blood, then you may want to give supplementary doses as well. I think if you mentioned obese patients, I don't know if that's an indication for repeated doses, but it certainly may be warrant looking at whether you need to give a higher dose as your first dose, just to make sure you get adequate tissue levels. But the main message is you don't need to give repeated doses unless there are very specific circumstances. And again, I think it's an area where there's a lot of misinformation and kind of varying practice. And a lot of people give the 3 doses just because that's what we've always done. And it certainly doesn't, if you're looking at cesarean sections with other surgical procedures as well, the evidence is overwhelmingly on the side of that the single dose is as good as 3 doses. So all you're doing with the other doses is exposing your patient to additional antibiotics with no real benefit. So I'm going to waffle a bit more. Just again, a message that we try and bring across to our students and hopefully other people as well. Surgical prophylaxis is an important part of preventing post-operative infection. But I mean, people also obviously practice good surgical technique, cleaning the surgical site, temperature control, glucose control. There's a whole range of other interventions that all need to be part of a package of preventing surgical site infections. So antibiotics is just one part of a bigger bundle. And I think we need to be careful not to say the antibiotics and the be all and end all of surgical site prophylaxis. Should be a very holistic approach. Okay, thanks.
Thank you so much for that, Prof. And as you rightly said, it's a whole bundle that incorporates the antimicrobial use, but also aseptic solution that you're using when you are cleaning the site in which you're going to be operating, the use of the presence or the lack of hair. Are you going to use clippers? Are you going to shave? There's quite a lot that actually goes into the prevention of SSIs, surgical site infections. But yeah, surgical antimicrobial prophylaxis, I think it's quite a booming topic. A lot of anesthesiologists, a lot of surgeons are showing interest. So hopefully in the future, one day we'll all speak with one voice as to what should be done when. And I think especially in this scenario, she's an elective, not an emergency. It's a cesarean section. You're expecting that incision to be clean. 1 dose should be sufficient. Thanks.
Okay, so that brings us to the end of this episode. That was fun. It was really, really interesting. I loved hearing everyone's perspectives on the case scenario. It was nice to see that we were, in fact, on the same page for most of these. Andrew, it was really, really great to have you on the show. We loved hearing your insights, your experience, as well as the academic components of the meta-analyses and the studies that you referred to. We hope you'll be able to join us again sometime in the future.
Definitely. Thank you very much for the invitation. It's been a pleasure being on here. And I think the microbe mail is obviously a fantastic initiative. I'm kind of blown away by all the social media that you are linked to. A lot of social media fundi, so I get kind of very lost if it goes beyond Facebook. So,
you must follow us on social media if you haven't yet.
Yeah, I do.
And the social media is very much thanks to Nongs and Fatima and Esther, who's always behind the scenes. So they really do an amazing job for us.
No, well done, guys.
Thanks. Fatima, you were amazing today. You've bravely taken on all of these scenarios, and I must say you honestly did a fantastic job. Thanks so much for participating. Can you give us a little bit of feedback on what your experience was like?
Thank you. I would also like to just give some advice to my fellow junior doctors.
Yeah.
Is that we should always be thinking about antimicrobial resistance. It's from this talk, I've realized that should be something that should be playing in the back of my mind every time I write a script. And another thing is that I should always stay up to date with guidelines. Things are ever changing, resistance patterns are changing, epidemiology is changing. So it's important to stay up to date with guidelines. And this has been a really great experience. I'm glad I've got to move from behind the TikTok to the podcast channel.
Thanks, Fatima. Thanks for that feedback and also for the advice for your colleagues as well. And Nonks, thank you for joining as co-host. I know you're going to be doing this more regularly, and it was lovely to have you on.
Yes, this is a really good episode to start off with, and I hope any subsequent episode will be just as insightful. Thank you so much, Prof, for all your insights on this topic, and thank you so much to Fatima. You've proven why you are a microbe mail messenger. I just have a message for the listeners. So if you enjoyed this game-based episode, you can catch our other Would You Rather episodes, including episode 33, which is Would You Rather, the bacterial version, episode 35, the virology version, and episode 38, the mycology version.
Thanks, Nonks. So one last reminder to send us feedback on this episode, follow, like, and share. Until next time, that's it from all of your microbe messengers. We'll see you again soon with more Contagious Mail.